We are glad to have you here with us. So just to say that the webinar is being recorded and we seek your indulgence for that. Good afternoon, participants. Good afternoon to our panelists and also to our speakers. My name is Alalade Oyeluluwa and I'll be moderating the webinar for today alongside my colleague Eva Steinberger from Robert Koch Institute. For the webinar, the theme of our webinar is implementing community-based participatory research in African settings, what works. And for this session, we'll be having the host, the principal investigator of the research, Dr. Chinwe Ochu, take us through the opening remarks and also introduce us to the COPE strategy, after which we'll have our keynote speaker, Professor Kadidia, to take us through the webinar topic for today. We also have our experienced panelists on the call already, and they'll be engaging in a discussion on community engagement strategies in participatory research, bridging the expert-lay divide. We also have time for question and answers, but for now, I'll hand over to my colleague Eva for her to take us through some housekeeping. Over to you, Eva. Thank you.
Thank you very much, Oyin, and hello everyone, and also a warm welcome from me. I'm Eva Steinberger and part of the COPE team, and I will support the technicalities for this webinar. And as you probably already noticed, your cameras and microphones are switched off. This is due to the fact that we have a large number of registrations, 190 in total. And as much as we would like to see your faces and hear your voices, we also would like to enable all of us to hear and see our speakers and panelists clearly. Also, we record the session, so this way we do not record your faces, voices, and names. For the Q&A, we would then ask you to use the chat box, and with the support of Oyin, we will then take back some of those questions back to the plenum. And yeah, so you don't have to worry, we will also guide you within the chat box so you know the time slots where to put in your questions. If there are any disruptions with network, etc., we would like you to be a little bit patient with us so that our speakers and panelists have the chance to rejoin or fix their technical difficulties, because you all know those moments, they can be quite frustrating. And then the best thing we can do is keep calm and then try to fix it, and then we go on. Once the webinar is over, you will automatically see a short post survey, and we would ask you to take just 1 minute of your time to fill it in so that we know what to improve for the next webinar, and maybe also we can then use the time to maybe celebrate if we know now that we hit a nerve with this webinar. So thank you very much, and with this I would like to hand back the word to Oyin.
Thank you very much for that, Eva, and welcome once again to everyone. To officially kick off the webinar, and I can assure you we're going to have like interesting discussions today. To kick off, we'll be inviting Dr. Chinwe Ochu. Oh, sorry, I was muted. So thank you, Eva, for that, and welcome everyone again. We won't be taking too much of our time, but I can assure you that we'll be having very interesting discussions today. To officially kick off, we'll be inviting Dr. Chinwe Ochu for our opening remarks and also to introduce us to what COPE is all about. And just to speak about Dr. Chinwe Ochu, she's a Doctor of Public Health degree student at the George Washington University, Milken Institute of Public Health, and in Washington, D.C. She's a director at the Nigeria Center for Disease Control and Prevention, NCDC, and she has led the Department of Planning, Research, and Statistics. Dr. Ochu is a medical doctor and public health specialist interested in innovative strategies for elevating community voices in public health. She is the principal investigator of this COPE strategy, and I would hand over to her now for our opening remarks and also to introduce the COPE strategy to us all. Over to you, Dr. Ochu, and welcome.
Yeah, hello everyone, and welcome to this first in the series of webinars that is organized by the COPE team. We will be discussing interesting strategies for engaging communities. But first, let me start with an overview of the COPE strategy and what we have done so far. What is COPE? COPE is community-based One Health participatory and empowerment strategy that is meant to empower communities by giving them the tools to identify their problems, their One Health problems, come up with solutions to them, and then implement those feasible and sustainable solutions without much dependence on the central government. For this presentation, I'll be sharing some community photos and videos that were taken by the community and sent to us to use to tell their success stories. So we believe that there is an agency within the community that we can unleash by giving them the tools to address their own problems. The goal of the strategy is to reduce the burden of community prioritize One Health challenges in Lassa fever endemic areas in Nigeria, and we want to demonstrate the effectiveness of the COPE strategy in addressing selected One Health challenges. So we piloted this strategy. We are piloting it in a Lassa fever high burden community in Ebonyi State, Nigeria. I will not be talking about the research component. I will be focusing on the strategy for this presentation. Our objectives cut across the various sectors of the One Health. We want to estimate the burden of Lassa fever before and after the intervention and describe changes in the intervention community compared to our control community, which will be receiving our routine risk communication approach, and then explore social behavioral factors related to Lassa fever and One Health challenges. We will also look at rodents because we know that Lassa fever is transmitted by rodents. The virus is carried by the mastomys rodent, that's multi-mammate rodents, and that comes in contact with food and human beings. When they come in contact with the body fluids of these rodents, they are likely to get infected. We want to determine the burden of Lassa virus in these rodents and identify the potential risk pathways for virus spillover. We also want to look at what environmental media we can detect the virus from, assess environmental sanitation conditions, and examine the relationship between poor housing conditions and vector abundance. The COPE strategy has 7 elements. The first one is community entry, which is very important. We want to establish rapport with the community before we do anything in the community. And then we will estimate the burden of Lassa fever in the community through a One Health risk assessment approach, and then bring the community together to conduct their own needs assessment, identify interventions, and then implement the interventions. Then afterwards, we will still conduct another One Health risk assessment to see if there's been any change, and then document our findings. We started the project through with an inception meeting in Abuja in April 2023 with the support of the leadership of the various partnering institutions. So how did we enter the community? First, we conducted advocacy visits to key stakeholders in the state and local government. The commissioners for health, agriculture, and environment, and other key stakeholders were visited, and we introduced the project to them. They gave us their buy-in, their commitment, and of course, they showed us great hospitality. We were able to eat garden egg and peanut butter, something you would want to try out, a very special delicacy. Then we went to the community and visited the traditional leader together with his cabinet, and we introduced the project to them and made it clear to them that this was their own project. They were to lead on it because we are using the highest level of community engagement, which is community leadership. They gave us their blessings, they asked questions, and we were able to address their questions. And they gave us their commitment and even provided somebody that joined us for the community sensitization exercise. They also hosted and took care of anthropologists who stayed in the community for several months. This was how we sounded. So the community, they are very religious and they like Christian music. So we used what they liked, the way they wanted to be reached, to approach them. And they came out to dance and were able to address their questions. We also met them where they were, in their stalls, in public places, and they asked us questions and we addressed them. We're able to reassure them that this was not just another project that would want to, come and exploit them, like they said some had done in the past, but that this was their own project, and that gave us their trust and commitment. Then we did our baseline One Health risk assessment. We selected data collectors from the community because we wanted the skills to be left within the community after the project. And we trained them alongside other data and sample collectors from the tertiary hospital that was partnering with us. They were very pleased. It was a very participatory training approach. And then at the end of it, they piloted the trained data collectors, piloted the e-questionnaire among community members that were dwelling in Abakaliki, but were not part of the research. Then we conducted the One Health Risk Assessment. We collected data and samples from humans, rodents, and targeted environmental sampling using spatial camera to monitor the movement of the rodents and then target our environmental sampling. Then the community came together to conduct a participatory needs assessment. We screened community-based facilitators who were going to, who were responsible for conducting these group sessions and identifying the needs of the community with the support of the leadership. These are the trained facilitators. One of them will be discussing in the panel, and we are very grateful to have her. She'll be sharing her experience with us. The community members themselves identified their problems and they prioritized them using these sticky notes. Those of them that were not literate, of course, because the facilitators were drawn from them, they could interpret to them, and we made sure that all voices were represented. It was very participatory. They had different groups, the male, the female, and then the youths. And then at the end of it, there was a town hall that brought together the different groups to validate the needs and the interventions that were prioritized. So it was very inclusive. We even had those that were vulnerable, especially those living with disabilities, who also made their voices heard. How did the community respond? What did they do? First, they set up central committee headed by the traditional leader, and then there were ward level committees that were supervising the implementation of the interventions, and these reported back to the central committee, which provided political leadership as well as resources for them to implement the interventions. The first thing they identified was poor sanitation. So they instituted a compulsory routine sanitation that once it is day for sanitation, all of them must participate in the sanitation before going about their routine businesses, and the community was very cooperative. Then the community-based facilitators led public sensitization and health education, meeting the people in marketplaces, in the churches, in the schools, in different places where they were, and then addressing their own people in the way that was culturally acceptable to them. They also plastered rodent holes in the houses. The central committee provided them with cement, which they used to plaster the to plaster the holes. And this was how it looked after such a hole was plastered. Finally, they crafted food storage baskets because they were leaving their food open in containers without lids. So they themselves, with the artisans from among them, they crafted these food baskets, and then they trained others through apprenticeship, so that many of them were now able to craft these baskets, produce them, and then they sold them at subsidized prices to households in the community. So this is one of them in action. Stop Lassa fever. So you'll agree with me that none of us could have done that as well as their trusted voices. Which institutions that are partnering in this project are the Nigeria Center for Disease Control and Prevention, the National Veterinary Research Institute, the University of Ibadan, and the Alex Ekweme Federal Teaching Hospital at Abakaliki in Nigeria. And then our international partners are the Robert Koch Institute and Frederick Loeffler's Institute of Germany. Our funder is the German government through the Global Health Protection Program, and we are very grateful to them. So this is a project that we believe that once implemented will empower communities to stop outbreaks. We believe that epidemics and pandemics start from the communities, and if we give the communities the tool to address their own health issues, we can stop the next epidemic as well as stop the next pandemic. So these are very wonderful members of the team that are blazing the trail on this important project, and on behalf of them, I want to say, Dejenu, back to you, Oyin and Eva.
Thank you very much, Dr. So that was wonderful, and for the in-depth introduction into what COPE is all about and how the community is championing providing solutions to their own problems. And so now we want to listen to our keynote speaker. She will be speaking on the webinar topic for today. We'll be bringing up Dr. Khadidiatu Ndiaye. She is an associate teaching professor in the Department of Prevention and Community Health and the director of the Public Health Communication and Marketing Program at the George Washington University. Dr. Ndiaye's research centers on culture, global health, and behavior change communication. She explores how culture impacts the fundamental understanding of health, as well as individual and communities' risks and behaviors. Our work highlights the unique health experiences of sub-Saharan African communities and their implications for not only understanding health risks, also designing contextually appropriate interventions. Join me to welcome Dr. Khadidiatu Ndiaye as she takes us through our keynote speech. Dr. Khadidiatu, over to you, ma'am.
Thank you so much. Can you all hear me okay?
Yes, we can hear you clearly.
Wonderful. Thank you so much. I'm going to start sharing if you don't mind. Okay, let me go ahead. Can you see the slides?
Yes, we can.
Okay, wonderful. Thank you so much for having me. I want to start by thanking Dr. Chinwe Ochu and the entire COPE team for having me today to speak on this very important topic. And frankly, after listening to Dr. Ochu's introduction, I'm like, you have all of the things that I'm going to talk about. So I should just say that let's refer to your presentation. Because you really exemplify some of the things that we're talking about. I will start today by just kind of talking, giving a brief introduction of what we, when we talk about CBPR, what we're talking about, but also in the African context, what are some of the issues and some of the factors that we need to consider. Then I will move into some practical consideration, talking about the idea of transparency, the idea of community entry process, and what are some of the ethical consideration that needs to be taken into context when we're talking about doing community-based participatory research, including a dissemination plan. And I'd like to say that I think it's important for all of us, all of the people who are joining us, who work with communities who are right there in the front line are the ones who have answers. So I want to end with posing some questions of some of the things that we have to consider as we go into, and I am confident that the team and all of you who are joining us today have the answers to the questions that are important when we're really thinking about engaging in community-based participatory research in African settings. So as I was just go ahead and kind of talk about the definition. And there was different ways that community-based participatory research and community-based efforts are taken into account. But I would like to use this one, I think, because it reflects an important element and another feature that we're talking about knowledge sharing. I don't pretend, and I believe the COPE team and everyone who don't pretend to come in with all of the answers. What we have for the most part is questions and some of the things that we've learned, but it is important for us to kind of talk about some of the work that we do, whether it's health promotion, whether it is formative research, so that we're engaged in health promotion, to kind of think about it in a collaboration phase. Because again, as I say, as a health communication specialist, I often say that when I work in different settings throughout the continent, that people have had ways and best practices existing for years. So instead of kind of thinking that we're introducing something new to them, it is important for us to kind of understand what have they been doing that has been working. And that's the same type of frame of mind and the same philosophy that I will approach this talk. Because I think when we're talking about centering community, this is something that's been a hallmark of African communities and African setting, regardless of the country. To our ability to understand how to center community and to value and respect our community norms are something that essentially I frankly believe that we are the one who should be sharing lessons with others on that. So when we talk about CPBR, we're talking about this collaborative effort among community, academic, and other stakeholders who gather and use research and data to build on the strength and priorities of the communities. I think it's no longer sharing. I don't know. Okay. I think it's sharing again. I can see it.
Yes.
Yes. Okay. Perfect. So we're talking about building on the strengths and priorities of the community for multi-level strategies to improve health and social equity. So what that means in practical terms is that we are not coming with all of the answers, and frankly, we're not coming with all of the questions. So to what extent are we doing this work in a way that allow us to try to work with the communities that we are interested in engaging in a way that allows them to be part of the process of setting these priorities and so and building on the strength. So I think it is important to kind of think about that. I also wanted to kind of to bring in this perspective from an organization called the Detroit Arc that really brings in an important element when we're talking about doing CPBR well, is the importance of making sure that this is not a one and done process. Ideally, when this is done well, this is a process that is always, this is ongoing. So we are maintaining our partnership, but it is important that we do so by first thinking about who are the ideal partners, what is our way of, what are our approaches and our strategies for finding out those partners, and then identifying what are some of the priority public health relationships that we talk, issues and questions that we want to address, conducting etiologic intervention and points of research, feeding back to the community, disseminating and translating, assessing and community. And this is, again, a process that we continue to start. So ideally, some of the work that we do is a process that keeps on going, and we are not there to collect data and go on, and the community will not hear from us anymore. So that is not really the value and the spirit of what CPBR is. When we're talking about doing CPBR in African context specifically, it is important that we understand that the plural aspect. So we're not the plurality of African context. So we have a complex mix of cultures, language, traditions that spread across the continent. So while we're talking about some best practices today, it's also important for us to put them in context, that what may work in one particular area may need to be adapted in a way to be able to reflect the needs and the priorities of another area. So it's important to really think about context in the plural and that understanding that it's not one. As I was pondering this question and thinking and preparing for this presentation, I thought it was important to also think about where are some of the lessons or the best practices coming from? And I would advance that what we're asking people to do and what we're asking, the engagement that we're asking, that we're promoting when we talk about effective CPBR is really grounded on existing practice in centering community, as I mentioned, which is a hallmark in a lot of the places that we all are coming from. So it is important for us to really think about it that way and say, what are some of the practices? So I'm going to talk about in a little bit about the idea of community entry. How do we engage? How do we approach people? And I'm sure depending, regardless of where you come in, there are existing practices in terms of who do you need to talk to first. So can we build on those? And I will go into going further, and I think it's important that as I said, that we are thinking about decolonizing this process and understanding that the expertise that we're looking for engaging is an expertise that exists into our communities, exists into our own realm. And in a way, we are the ones who have the opportunity to continue to share this with the global community, because these practices are there, and these are the practices that have been working, have been effective, because we know who to engage. We know how to navigate and understand what are some of the hierarchies in the different places that we work. So I think that is important to kind of think about it that way. And that is really the frame of mind that I approach it with. That is the frame of mind that I use as I'm approaching this talk. So with that in mind, I just want to kind of get into, and I want to start, and I'm excited about the discussion that we're going to be having. But in starting, I just want to get into some of these practical considerations. And I have identified multiple, one of them being into what do we do and what is the engagement process looks like. There's also the issue of transparency. So as I mentioned earlier in the definition, this is the relationship that we're building. So it is important that we're transparent in how we go about. So transparency, the idea of ethics, and the idea of community entry and community engagement. How do we even approach it are things that I'm going to be discussing in these following slides. Starting with the idea of goal transparency. I think it is important for us to be able to really discuss and decide before, as we are designing and thinking about these projects, what are we able to do? So if you think about community involvement as a continuum, we can't just do some outreach and then feel like we have accomplished something that's a truly participatory endeavor. And sometimes there are times where the idea of getting to shared leadership is where we want to be, but because of the times, of the resources, and of the resources and time and expertise that we have within the team, we're not able to do that. So it's important for us to be honest about, within the scope of what we have to do, within the resources that we have, where do we fit into this continuum? Because shared leadership is really what we're after, but to what extent are we able to achieve it within one project? So with that said, it's important to really think about it in terms of outreach. So thinking about strong community involvement, communication flow from one to the other, providing community entities coexist. Optimally, you are establishing what all you can do with outreach is establishing community channels. So the next stage is something that we call consult, where you have more community involvement, where you are thinking about communication flow with the community, and then you're seeking answers, you're getting information and feedback from the community. And the different entities within the communities share their information, and you're developing connection. Again, we're still not talking about true collaboration yet. Next, we can talk about involvement, where you have a better community involvement, where you have communication flow on both ways. You have more participation from on issues, entities, they will cooperate with each other. So you are starting to increase cooperation. It takes getting to this level where we're starting to talk about collaboration and getting to our ultimate goal of shared leadership. Community involvement, you have parties on each aspect of the project, from the development, meaning from you collecting your data to designing some of the solutions. And you have bidirectional communication, meaning that as much as you are the one who's sharing with the community, there are established mechanisms for them to share with you as well. And you are having not only partnership building and trust building. And I think when we're talking about trust building, this also brings in an important element that we have to think about, the element of time. As we know, this is not something that's done quickly. So we're talking about building trust, building community. This is something that takes time. This is something that takes multiple interactions. So that's why I mentioned earlier that it's important for us to be transparent about what we're able to accomplish within the timeline that we have. And finally, this is what we aim for, is where you have a strong bidirectional relationship. Final decision making is at the community level. Entities have formed strong partnership structures, and you have a broader health outcome affecting broader community, and you have a strong bidirectional trust. They trust you, you trust them. So that is important to kind of think about it that way. With that said, as we think about community, one of the first practical consideration beyond the transparency in which we should approach and essentially being very candid about what we can accomplish is and setting expectations, is also the idea of community entry process. How do we engage? I didn't mention I'm from Senegal, and in a lot of our communities, how you get into the community, how you engage the first time could make or break what the interaction and the collaboration is. So it's important that we think about it as a process and that we are very intentional in in designing what is our community entry process. So I pose some of the questions that I will pose as we get into the discussion is why do we conceptualize community entry as a process? What are some of the important ethical considerations? And what are some of the steps that we engage in? I will in the process share some of the things that we did in some of the research projects that we have been engaged in, but I'm also curious to hear what are some of the things that you have to continue in. So I think it's important to understand that a lot of these things that are happening and that will be done are things that we need to happen before we even are getting into the formal community entry. So first is, do we have, and again, the transparency and being very candid, do we as a team have the competencies and the skills to be able to enter the community? And because we understand the context, because we understand the dynamics, do we have the skills to do that? Do we have an understanding of community systems? And that includes both the formal networks, including what is the leadership that's put there, but also what are some of the informal leadership networks? In some of the work that we've done in the past, we talk about the idea of what is happening in the household. When you're talking about informal, what is the role of women in private sphere and some of those leadership systems that exist in the compounds and in the household. We also want to look at who is affected by health and social issues. We look at who is marginalized, because I think sometimes if we stick with just what is the public traditional hierarchy, we may be missing out what are some of the, within communities, what are some of the groups that are marginalized for multiple reasons. So it's important for us to try to understand that. Another element that's important is understanding the history of collective action by the community. What are some of the groups that are existing? How have they organized? So in some of the projects in Senegal, for instance, they involve using something organization called Bajenu Gox. Bajenu Gox is the aunt or the elder aunt of the community. And these women have been engaged in maternal and child health promotion because this is a role that they already had. They served an important role in collective action within the community. So they were the ones who were engaged and trained when it came to maternal and child health. What are some of the tools that we can employ? And I'll talk about some things that are more technical and some things that I think we are able to do relatively easy working in collaboration. So there is the more formal social network analysis, existing platform analysis. So for instance, we talk about in some of my courses, we talk about something called an information ecosystem analysis. So those are things that are more academics. But there are things that we can do. Can we do walk with the community? Can we talk with community members? Can we do walk with some of the people who are gatekeepers? Can we do mapping and spatial map? Can we do gender analysis? Can we explore what are some of the community and orientations that are available in the communities that we work with? So I want to share, this is an example of a project that we did in Northern Nigeria about 12 years ago. And I want to just kind of talk about our process. So this was a polio vaccination. So we were trying to understand the barriers and facilitators of polio vaccine acceptance at that time. And our process was, first, we had collaborators. So coming from a university in the West and coming into the context, it was important. And we had some members of our team who were from Nigeria, but still, it was important for us to have local university collaborators. So we had local university collaborators who were engaged before we even thought about coming into Nigeria. And then we identified who are the community leaders. we had correspondence, so letters that our local partners involved share with these community members. And this is even before we came. And when we came, we had their permission first, which is something that's important. And we started with meetings like this. So this is one of the meetings. I'm sitting right here, and we have some of our collaborators where we met with the local emir in each of these towns that we went to introduce ourselves, talk about the project, to answer the questions. And that was the first step into getting into the community. And with their guide and their leadership and their permission, we're then engaged into more of the data collection. So one thing that I want to talk about also is when we talk about other practical consideration, because I do want to allow time for conversation and discussion, is to really talk to engage. It was important for us to engage with our partners into identifying what are some of the things that are part of the process. One of them was we spent a lot of time really discussing would you express our appreciation and incentive. So working with our institutional review board, there are some guidelines for that. But we wanted to make sure that also those guidelines were in line with what the norms and the practices in the communities that we work. And sometimes I would admit that this process wasn't easy because it meant that we were going back and forth with our institutional review board. But in this case, for instance, we're trying to figure out, we're interviewing mothers with children under 5. So we're trying to figure out what was the way for us to engage and give them a token of appreciation. And we kind of discuss so of course, when we're talking about token of appreciation, we're talking about, I'm sorry, I just realized that we're talking about things like, is money the best way? Is there something else? What are some of the ramifications in the context, in the household? We're getting money, make it something that was complicated. In this particular case, what we ended up giving the women were fabric so they can make clothing. So that's one of the things that after doing multiple consultation. Another element, and again, it goes back to how this is a collaboration, an existing collaboration and a relationship, was for us to have a dissemination plan. So given the information, so once we collected, this was a research project. So this was step 1 of a research project to be able to create a health promotion campaign. It was important for us to be able to disseminate the research. So what that meant was as we're planning, we had the team come up with a plan in how we would go back and share information with different entities in the community. So that meant being able to translate the research, because it's not if you have to translate it in a way that it's useful. So that's one of the things that we do. And we also kind of think about ethics in terms of privacy and confidentiality. How do we protect the confidentiality of different members of the community? So that's one of the things that we worked on, and we would have different types of consultations. And this become more important depending of the issue. So for someone who's done work to spend a lot of time working on HIV, that was one of the things that was very important. And it came in different ways. So for instance, I remember going back and forth with IRB about having a written paper that said that we are interviewing the informed consent. And to what extent could we create an informed consent that wasn't disclosing the information? So with this practical consideration in mind, I challenge you, and in the discussion, to kind of think about what else within your community and community-centered are practices that are existing that we can incorporate in designing these best practices when we're talking about community-based participatory research. If we're centering communities, what are some of the norms that people need to understand, and to what extent can we build on those things? So that's where I will stop now, and so that we have more time with questions. So I thank you for your time, and I'm looking forward to the panelist discussion and to a lively conversation around these topics. Thank you.
Thank you, Prof. That was like a very, very wonderful presentation. Took different notes. You spoke about decolonizing research, ensuring even during the community entry, ensuring confidentiality, and also practical considerations. I think that's one major.
Thank you, everyone. It was my pleasure, and I'm excited. I intentionally kept it somewhat short because I think the body of knowledge is here, and I would love to engage in a lively discussion.
And if you're speaking, you're muted.
Okay, I think my
Glad that-
colleague is doesn't have a voice right now. So I will take over for the second. And would like to thank you first for your presentation. There's also a comment in the chat box. Thanks for the insights to you. Thank you really much. And one question to you, I would like to read out loud, if you don't mind, so that we have this discussion you talked about. Do the funders consider time to build trust and partnerships with community members in the research timeline?
That's a great question. I would say that I think we are better than where we were with this process in terms of being able to advocate for that than 10 years or 20 years ago, because the sad part, and I say this without is people have learned from some of the failures of lacking to do that when you come, for instance, public health emergency. So I think we are better in terms of having that consideration in the funding. But I still think there is way to go. And part of some of the work and part of having panels like this and having this conversation is for us to advocate for this process for the time, because part of, and the tricky part is that we don't necessarily always know. We can really, this is not an exact science, depending how difficult the topic is, depending on other contextual issues. We can't say that this is the process that will take 3 months. It may take 3 months sometime, it may take a little longer. So part of what we have to do is for us to kind of use our best estimates and then kind of also advocate for why this is a process that's important. So I was to just kind of reiterate, I think we are better in terms of funders considering that, but I don't think it's still as valued as it should be.
Okay, thank you so much. I have to admit it's a really interesting question about dynamic funding options. Another question for you from the chat box I would like to read out to you. How
Sure.
far do your projects go in the direction of shared leadership? How do you deal with limits to shared leadership in global health work, such as where the funding is managed? Thank you.
Wow, these are great questions. And I think I was alluding to that when I said transparent. Shared leadership is where we want to be. And I can't say that I have achieved that in all of our projects. I would say that most of our projects, because of the funding structures needing to be and the required of, so for instance, when we funded for US federal money or the funding structures requiring us to have the majority of the funding in our universities, for instance, we are unable to get quite to that level. So I think most of our projects are still in collaboration and that's why I think it is important to understand that we still have a lot of work to do. And it is a harder process. We tend to be able to work and kind of negotiate and saying, so for instance, so I didn't say part of some of the work that I do, I'm the instructional lead for the Atlantic Fellows for Health Equity. And we talk about this term that I think is value, is if we're talking about equity and social values, can we leave out those values? And it is sometimes difficult within the strains of funding, within the strains of having to budget and where the money is housed. So it is difficult, it is challenging, and it's not something that we achieve on every project.
Thank you very much. A last question to you from the chat box. How have you determined the issues to address over others in your previous projects?
So I think, again, it goes into a continuum. There are some times where we've had, so with the polio project that I was talking about, we had some questions that our funder, in that case, it was the World Health Organization, wanted to do a very deep dive, interrogation into what are some of the facilitated and barriers of polio vaccination. So that guided our study. So with that in mind, we were saying, okay, we know these are the questions that we have to address. How can we get them? How can we make our inquiry within the scope of these questions as community-minded as possible? So that's one of the things. In another project where we were, that I don't think I mentioned it, so we were looking at African communities, African immigrants in China. We started that project with a blank slate. We know that there was health issue with those communities, but because there has not been a lot of engagement, it was important for us to just kind of start and say, and what is going on? What are some of the health issues? So in that case, what those health priorities of this immigrant population, of this African immigration population specifically in China, was determined by engaging them and having this conversation with not only the immigrant themselves, but the different leaders of these African immigrant communities.
Okay, thank you very much. I give my colleague a few minutes time to share her screen, but actually in the meantime, maybe one more question because everybody's very excited about it.
Thank you.
Use of incentives to drive acceptance, participation, and support is a great one. However, in research that could affect the quality and outcome of the research, how do you address that in the study and with your funders?
So is the question about the scope of the incentive? I don't know if the speaker can. So I'm gonna assume that's what they're asking. If that's not the case, please stop me and correct me. I think personally, as somebody who come from these settings, who come from an African community, who's seen sometimes the resource challenges that we have, this is something that I struggle with, because there is this this balance. We want to be able to thank people and appreciate their time, but we don't want to offer incentive in a way that make it coercive, that people have no choice because the incentive, so it's not really a choice. So that's the foundation of ethical research, is the fact that you are presenting the research in the way that people have a way to say no. So one of the things that we've done is to be able to kind of keep the incentive at that level that is that's not coercive. And then if we have funding, depending on the things that we do, we find other ways to kind of improve. So in a project that we had in Senegal, what we did was the incentive was maybe the equivalent of $3. I can't remember, $3 or $4. But what we did, we also provide, this was a diabetes project, we also provided people with an A1C test, because, and that's something, that's another way that we're able to also appreciate their participation. And sometimes when we're doing focus group, there's other ways where we provide, again, that incentive that fits the needs of what is ethical and is not coercive. And then we offer a meal as well. In one of the projects, we're able to put in that we're going to give the community, when we came back with the dissemination plan, we're going to purchase projectors so that they are able to share, so that movies and different film can be put in. So we try to figure out how we can enhance, because I do think, I struggle with the fact that if I was in the US, me being able to give someone $50 is not a problem. But when I come into these different studies, I cannot do that. So I try to figure out what are some of the other ways that we can maintain the incentive, but at the same time find other ways where we can enhance, because I believe that the time of these people that we come in rural communities is just as valuable as the time of the people we work with in Washington, D.C.
Thank you very much for your
Mhm.
presentation and for answering all those questions. There are more, but I see the last one is already clapping to your answer, the one who stated the question, so I think he's happy with it.
Okay,
There's
thank
another
you.
one, but
Mhm.
maybe you could also look into the chat and write your answers there if you don't mind throughout the next few minutes, and
Mhm.
then we would go on with the panel.
Absolutely,
Thank you
I would
so
love to do
much.
that. Thank you.
Great, thank you. Okay. So my colleague will take over now. I think she's connected to the audio. Oyin, over to you if you're able to.
Thank you very much, Eva. And yeah, just some internet challenges. Thank you very much. So we'll move straight into the panel discussion. And the panel session is going to be moderated by Dr. Hutse Zoha. Dr. Hutse Zoha currently works as the educational lead in the IPC sub-project of the NICADE project, that is Nigerian Capacity Development Project, a collaboration and partnership between RKI and the NCDC since 2018. She is an adult educationalist and expert in learning. She is also an associate professor in the Department of Education at the University of Education, Heidelberg, where she co-founded, collaborated with, and headed the Health Promotion and Prevention Program. She is on the advisory board of the Professional Association for Health Promotion in Germany and a member of the German Society for Educational Science. Dr. Hutse Zoha, you can click on your video. Welcome, ma. And while she's turning on her video, I would also introduce the panelists. Our first panelist is Mrs. Bridget Oji. Mrs. Bridget Oji, she is a co-trained community. She's a corporate community-based facilitator. She's an experienced teacher at the community primary school at Orizo Community, which is a COPE community. She has an in-depth understanding of the social, cultural, and economic dynamics of the COPE intervention area. She's actively involved in our community activities, and she skillfully navigates relationship and hierarchies, building and maintaining trust. Our efforts in this project have been instrumental in fostering community ownership and support. Welcome, Mrs. Bridget. Our next panelist is the Acting Director of Science and Innovation at the Africa Centers for Disease Control and Prevention. He currently works as Program Manager at the Africa CDC Mastercard Foundation Saving Lives and Livelihoods Initiative. He was the co-founder and Director General of the National Public Health Institute of Liberia and also CEO of an NGO, Refuge Place International in Liberia and USA, to address the issues of access to quality and affordable care. Welcome, Dr. Masoka Fala. Also, our next panelist, which is not the last, is Dr. Olayinka Badmos. She's a Deputy Project Director with the USAID-funded Breakthrough Action Nigeria project at Johns Hopkins. At the Johns Hopkins Center for Communication Programs, where she oversees the Global Health Security portfolio. She is a certified Global Health Projects Management professional who has worked across sectors and at different levels, focused on health system strengthening. Dr. Olayinka has led implementation research that has resulted in policy review and scale-up of life-saving interventions. She is passionate about improving health outcomes by advocating for a shift in the way we address global health challenges. Her quote is, "Making individuals, families, and communities at the center of the approach will encourage participation, ownership, and drive that will lead to the desired change." And last but not the least is Professor Oka Obono. Is among Africa's leading social science research methodologists. He's a distinguished professor of sociology and ethnodemography at the University of Ibadan and a visiting professor in advanced research methods and policy at the Milton Magai Technical University in Freetown. He has served as a temporary advisor and PI in numerous WHO community-based studies since 1996. He is the chairman of Case Studies Consulting Limited, and was also recently appointed the acting vice chancellor of the University of Sierra Leone. Welcome to all our panelists and also to the moderator. I'll be handing over to Dr. Ute Zoa now to moderate this panel discussion. Thank you very much. Dr. Ute, over to you.
Thank you very much, Yin. Thank you. Warm welcome from my side. Thank you very much for this nice introduction of us as panel discussion and panelists. Maybe I can invite also our colleagues from the panel to switch on your cameras. I don't know if that could work. Yes, hello. Good evening, good afternoon. I'm with you in Nigeria. I'm sitting right now in Abuja. So good afternoon to all of you. Bridget, does it work with the camera? Yeah, I see you are trying, I think. Thank you very much for giving me the chance to be part of this wonderful opening webinar of the COPE project. I'm enjoying it very much, and we had already with these two key speakers, I mean, a lot of things to discuss, I think. Thank you very much. My name is Ute Zocher. As you heard, I'm part of another project which is also dealing with a participatory approach to learning into systems. And I liked it particularly when I heard from the key speaker before. Thank you for your great presentation, what you said about trust, time, relationship. I think this is somehow at the core of participatory approaches, but also on other research and program interventions, how to relate, how to create this wonderful dynamic between people coming from somewhere outside, coming in some inside, and how do we work together, particularly when we have to deal with complex situation challenges, and particularly when we want to change real life conditions or situations. This panel will take 40 minutes about, I think. I asked our panelists to prepare, to think about an opening statement so that everybody, first of all, has a chance to voice out his and her thoughts. And then maybe we get into a more vital discussion. We have so many questions already in the room. Certainly I prepared some others, but sorry, the housekeeping is. Sorry. That we can get into a very vital discussion. The question of our panel today is if community engagement strategies and participatory research, is that a bridging of the expert-lay divide? So somehow the question also, is there a need to bridge something? Is there an expert and a lay divide? Who is the expert? Who is the lay in this context? And who is learning from whom? I ask everybody on the panel maybe to start with 2-minute statements with your perspective on this relationship, with your backgrounds. We heard you are coming from very different organizations. You are part of the COPE project, Bridget. You are a community facilitator in this project. We have the university here presented, the African CDC, and the Breakthrough Action Nigeria, and as an NGO with you, Dr. Olayinka. So I would like to hear from you first to start. What is your perspective on this relationship of expert and lay? And I would like to invite Dr. Olayinka to start with her perspective. Thank you. Jetzt you the floor. Thank you.
Thank you so much, Uti, and hello everyone from wherever you're calling from or listening to this morning, afternoon, evening. So when we look at expert-led divide, is there really something like that? I'll say yes. And speak from the lens of who is an expert and what makes you an expert. Expert of what? Opinion, expert of my life, expert of what exactly are you an expert on? I'm of the opinion of a shared approach. There shouldn't be a divide. It should rather be a collaborative approach of, yes, you might have an experience, maybe studying that particular issue, disease, as it were, from, again, multiple countries. But there are also people with lived experience. There are also people with, so yes, I might be talking through Lassa fever now, but I've never experienced Lassa fever. What does that make me? An expert or a lay? But my work involves Lassa fever, so I get to study, I get to read about it, I get to follow people that have lived about it, but that doesn't mean my opinion or my knowledge as well is not enough. So in my own, there shouldn't be a divide. It should be a participatory approach to understanding the different contexts. And that's why for the work we do, the human-centered design, we always look at 4 voices, okay? So voice of the designer, someone that is actively listening and trying to understand what the issue is. Voice of, yes, the expert, someone that is knowledgeable in that field. Voice of the user, or voice of, and then the voice of experience, people that have had experience, lived experience of that. So bringing the different 4 voices together helps us to have a better understanding of the context and issue. So in essence, one, it's a participatory collaborative approach. One does not override or supersede the other. Thank you.
Thank you very much. You're offering 4 voices and a shared collaboration instead of divide and the gap. Thank you very much. We will come back to that. I would like to hear Bridget to this topic. Can you hear us, Bridget? Maybe can we switch off our cameras for a second? Maybe it's a challenge.
Okay, Bridget will speak soon, but we can move on to like some other panelists. I'm trying to resolve some technical issues with her.
Okay, thank you. All right. Whenever she can speak, please give me a sign that we can get her on board.
All right, thank you.
Okay, so I would like to invite Mosoka Fala to give us your perspective as acting director of the African CDC. So how do you look at this relationship? Let's call it relationship.
Thank you so much. I had the privilege of being actively involved in 2 major outbreaks. The 2014-2015 Ebola outbreak and the 2018 outbreak in the DRC, in the northeast DRC. And I quickly realized, as a result of the consequences of doing research the traditional way, that is a fine and fragile line, that if the community voices are not heard, if there is a haste, if there is increased power imbalance, there can be violence, and you can defeat the entire ability to contain an outbreak. I was involved in an outbreak. There's no time. We wanted to, there was Ebola in a slum community of 70,000 persons in about 5,000 houses, densely populated area. There was no treatment unit, and we decided to set up a makeshift treatment unit in the midst without engaging the community. It exploded in our faces. People died. The military was deployed. Then we had to go back to community-based participatory process, and that helped us to end the outbreak. I don't have the time to go through all of the detail. And then 2018, I was in Goma, in the DRC, where many of the response workers were attacked and killed by a group called the Mia, and I managed to infiltrate and understood their aspirations and the fear that were driving them to attack. Basically giving them the ability to hear their voice, to listen to what they construe as their realities, and to work with them with a solution. When I came from there, I wrote a 2-pager for the US CDC director and said, if we are going to end the outbreak, we have to believe that we don't know everything. That whatever actions these people are taking, you may think it is resistance, but there are forces driving them. I know we speak about compensation and remuneration, what we call the Ebola economy. We come there as experts, we bring the anthropologists in their very expensive SUVs, and they get a lot of money every day. When it comes to giving money down to the cleaners and the common people, we say, no, we shouldn't give them money. And so one of the guys said to me, let me tell you something. If you hire my brother as your cook or as your driver, and my nephew live without bread, I will not attack you, because if I attack you, I'm attacking the source of feeding my son. You have to understand how we think. We've never succeeded in understanding how the community think, on what drive their actions, and we think we are the expert. I came from Harvard, and I thought I understood the problem until I got humiliated and humble, and I changed the entire strategy and say, I will be a listener. I will listen to the communities. I will listen to their problems. Then I will work with them. We'll co-create the solution. As a result of that, from resistance in Liberia, we were able to reverse the outbreak, where we're seeing 200 cases a day. That community became the first case that got to zero. We actually published a paper called Getting to Zero. Participatory process is important. Hearing the voices, understanding the nuances is a way to end outbreak. And I think I have known for the last 10 years, than being in the heat of outbreak, and I realized one thing, the knowledge and the power, there is an imbalance. The people that have lived with the situation have a knowledge that we need to learn, and together with our knowledge, co-create the solution. Thank you very much.
Thank you very much for this statement. And I mean, it's amazing if you think about that active listening to the voices, give the voices also the possibility to come out and listen to them, is finally the tool, the instrument to enter an outbreak of this dimension. That brings me to something what we in the participatory approach to learning and systems also always says, that is somehow expert meets expert. And that means also that everybody is a learner meets learner. So it's not, it's a dynamic relationship, and if people work together, they learn from each other. And even coming from Harvard doesn't mean that you know everything, for sure. For me, as an educationalist in this field of public health, it's amazing to hear that listening to people can stop an outbreak. So thank you very much for this perspective. And I try again with Bridget, technical support, Eva. Do you
start with Bridget?
Yeah, do you have a message for me, for Bridget?
Yes, she will speak now, but probably her video is off.
Okay.
Hi, everyone. Good afternoon, good
Bridget,
evening,
yeah.
everyone.
Hi, hello, good evening to you, Bridget. Good to hear your voice. Please.
Good evening, Ma.
Hi,
Greetings
hello.
to everyone.
Thank you so much. Thank you so much for joining our panel.
Thank you.
We would love to hear from you about how do you think, who was in COPE, who was the expert, who was the lay? What is your perspective on this collaboration? Can you give us some insights?
Okay. The expert is someone who knows it all. For example, COPE, concerning Lassa fever program, the expert is COPE. They know it all. They have all the knowledges, what it takes to stop Lassa fever. Then delay are the commoner, people that they don't know anything. They only know what is around them. So they only know what is around them in the community, coming down to the community, delay. They know what is in their environment. So they don't know much about COPE or Lassa fever. Then the expert now, coming to the community, the expert, with all the knowledges, the expert, you listen to the problems of those community members because they have their problems and their challenges. When you get their needs, you know their problems, their challenges, how they live in their community, what they do in their community, what they do when they are sick. You will get to know every bit of them about how they live. From there, you can make a better result of what you want. So COPE, as community-based One Health Participatory Empowerment, came to our community, Orizo, in Umuome, Ebonyi State. They came with so many good things to Orizo community. When COPE has not come, our people, we experience so many things. We eat rats. We toilet in the bush. We go to toilet in the bush. We have holes in our house that we don't even know what to do about it. So, but COPE came and they made us to understand that rat is a deadly animal. Our people used to burn bushes. So when they burn bushes, those rodents from the bush will now run and enter into our houses, which is very dangerous to our health. So COPE made us to understand that rats is deadly and that rats are carriers of Lassa fever. And Lassa fever is a deadly disease. Our people don't know what is Lassa fever, but when COPE came, we understand what is Lassa fever. So the idea of keeping our houses clean in our community, we keep our houses clean. This idea of environmental sanitation in our market, in our compounds, this idea of not going to toilet in the bush is not there anymore. The idea of not eating rats, our people will no more eat rats. So they see rats now as a deadly disease. They see rats as poisonous as anything. Anytime they see rats, they run away from it. They make sure they kill it, and we don't have anything. Even in our houses now, you hardly see rats in our houses. Then the blocking of holes right now is ongoing in our community. Everybody is eager. Our Royal Highness, as the chairman of COPE in Orizo community, brought bags of cement for us to block all the holes in our houses, and it is ongoing now. Then this idea of building toilets. Formerly, our people, when they build their houses, they don't build toilets. But now, they started it with the ward chairman. So each of them, they have built toilets in their compounds. So showing others good examples. So from there, other people will also be building toilets. We no more go to toilet in the bush. COPE brought so many good things to our people. In the community, as the lay people, we don't know anything. They are farmers. They interact with the animals. Sometimes, for example, animals can, something like snake can bite somebody. The person will use the little knowledge They will use the little knowledge they have, maybe by plugging one leaf or the other to treat the thing. Then another example is that COPE made us to understand. COPE taught us so many things. For example, now, I, as a primary school teacher, and the people of my community, we discovered that rats don't excrete where it is not eaten. It is when rat is eating food that it excretes on that food. So this idea of learning skill, we learn how to weave baskets, and we learn also how to weave the iron basket too. And all those things are in everyone's house right now in my community, because our Royal Highness made it sure that every home have that basket or that iron basket, and we use it to pack our foods. Rats don't enter inside those baskets. Our foods are secured in the basket. So the experts should have a listening ear. When they come down to the community, they have to work connectively with the lay. They have to listen, to have a good listening ear, get their needs, their challenges. Then from there, they can get a better result of solving this problem of Lassa fever. Another example again is that in my community, when we are sick, we prefer going to herbalists to treat us. We take herbal medicines. But since COPE came to our community, we no more take herbs. We go to the health center. When you go to the health center, you tell them what is wrong with you. If it is headache, they will know how the headache started, how all the signs and symptoms. If it is Lassa fever, they will know. If it is not Lassa fever, you will be treated and you will go. The people of my community, they have known all the signs and symptoms of Lassa fever. So when anyone is having headache, because one of the signs of Lassa fever is headache, it starts with headache. And when somebody
Is it only me who can't hear Bridget anymore? Hello, can you hear me?
No, we can't hear her. Yeah.
Okay. Okay, I mean, there were a lot of information going on. I didn't want to interrupt. So, Bridget, when you come back, please, we have still time to listen. But I really would love also to hear from Prof, from Okaobono, from Ibadan, from the university. How is your perspective? You heard from Bridget, experts have to come and to listen, and a lot of things change now in her community. What do you think? How is your perspective on that? Please, the floor is yours.
Thank you very much. I've been about listening. In my field, we have two concepts as the beginning point of research, and it corresponds perhaps in the physical natural sciences with the idea of observation. The first indeed is listening, and there's a particular concept which we refer to as epoche. Epoche is the deliberate suspension of virtually everything you know or think you do before you get to the field. And it's really kind of self-contradictory, because after all, you do know some things, but all the same, there's the sense of what we describe as explicit awareness. Going in the field and continually, regarding yourself as somebody who doesn't know anything about that at all, and using what the community has to offer as the beginning point of your knowledge. And that's how we do it in sociology, in ethnography, and so on. So it's really heartwarming to come to a COPE strategy that is an embodiment of precisely that kind of perspective. I find that really rich and encouraging. And I think, like when the lead speaker was talking, the idea of spending so much time in mobilization, you know, it speaks of cultural sensitivity, you know, not just ramming in a program through like that. That sometimes becomes problematic. So I think my statements will be at two general level: deep satisfaction and complete happiness with what I'm hearing about the COPE interventions and how they unfolded those. That's within that specific context. And then more broadly, a look at some experiences, incidentally also with Ebola, like Mosoko Fala was talking about. I'm recalling here in 2012, the outbreak of Ebola in Uganda, and I was invited by the World Health Organization to come have a look at that. The transmission patterns of that particular outbreak were clear, but the index case had not been identified. And for as long as that was the case, the risk remained. Here was a classic case where, based on the zoonotic hypothesis that the experts came with, they left with inconclusive results, thinking, for example, that the index case was somebody who could not have been the index case. And the person who could have been the index case was not interrogated at all. The use of significant others, visits even to speak with pastors and principals of schools where presumed Ebola patients had died. Like, I went to a church and the mat on which a patient had lain for days, bleeding and all that, before he finally died was there. And the pastor was saying to me that nobody had come. 40 ecologists had visited that community. Nobody had spoken with him about that. And then the person that they thought was the index case, Winnie Babazi was her name, a 16-year-old housewife. Nobody has spoken to the husband, Kubalikenda Mbozi, who had actually been on the same bed with her the day before she died. He was a principal caregiver. He went through all she went through with her, but somehow he never came down with Ebola. This was one spectacular case for me where the divide between experts and lay people had broken down, because there was complete skepticism on the part of the community. The community was raising arguments based on what they had been taught about Ebola by the expert scientific community, and then showing that, you know, the expectations didn't hold at all, you know, empirically. And yet there was denial and pushback from the expert medical community. It was an incredible time for my team because people were not raising ideas about witchcraft. They were not talking about sorcery. There wasn't anything like that. They were raising sound epidemiological ideas about what Ebola was, what they had been taught previously about Ebola, and for instance, the concentration of mortality within a single compound. Why was it not distributed? These were legitimate questions that the community was asking. But guess what they were saying to us? But that who is going to listen to them? They are just people who don't know anything. It was heartbreaking from a scientific angle for me to hear human beings talk like that we can actually be dismissive of what people had observed based on what we had told them. And just because they were the ones saying it back to us, you know. So to start with, that told me that generically, the split between experts and lay communities is something that we need to be very intentional about deconstructing with certain kinds of outbreaks or certain kinds of social problems. And I like the idea that one of the panelists has said, I think it's Olayinka, namely that there are sectors, maybe in the pharmacognosy or so, where yes, it's very clear that's a body of specialized knowledge that's possessed by some people. That's true. But when you look at onchocerciasis back in the day, you see that there was that kind of drug, mectizan, and then you had to get the community to realize that a single dose per year was what it needed to get rid of that particular kind of disease. And it was through CDDs, community-directed distributors, that this was done. I think the CDTI, the Community-Directed Treatment with Ivermectin program of the African onchocerciasis program on onchocerciasis control is very illustrative of what real mutually respectful collaboration can be like, even when there are people who are the designated experts and they are willing to share their knowledge with a so-called lay community across an entire continent. And there was the original pushback from the established medical community, but eventually onchocerciasis was eradicated through a strategy that involved mutual respect between communities of experts, and what have you. So I think that this presents occasion, listening to what Fala was talking about, from my own experience, this presents occasion for us not to go into the field, even when we do know that some people have specialized knowledge, with this kind of dichotomy between experts and lay people, because if we are not careful, it's going to perpetuate the embodiment of power relations that exist both at the economic sphere. This time you are bringing it into epidemiology, at the political sphere, at the historical sphere. There will be members of that community. When you talk about lay communities, there's likely to be a professor of parasitology who is a member of that community, who only visits home maybe on weekends or once a month. Is still part of the community. The community is no longer as static as it used to be. It's fully decentralized now. You have people living outside that physical boundary, and they are still regarding that place at home. And through their utterances, through their contributions to infrastructural development, through the kind of support they provide for scholarships, information they give, they sort of interfere with the body of knowledge that exists in that community. So when we say community, and we overlook the fact that there are experts, people you would regard as experts, if you met them elsewhere, if you met them outside that particular African village, we miss some vital point somewhere. So I think we need to deconstruct that dichotomy. We need to follow the path that I'm hearing COPE is following. I think it's really promising, because it's easier to sustain that kind of difference in epidemiology, for example. But there are certain kinds of challenges that human beings face, like in maybe criminology and all of that, outside the kind of thing where we sitting here would regard ourselves as experts, where you certainly find that kind of division would not be tenable. But I think my big summary here is I'm really, really, really happy to hear that a project of this magnitude is listening, is following the kind of epoches that some of us have canvassed for years. Now seeing how it is being rolled out in this particular project is really heartwarming, and I'm really happy to hear this. Thank you.
Thank you very much for your statements. Thank you very much. Again, we see that every body of knowledge can change. and everyone part of this endeavor of a project or a research or whatever is a learner in the field. And particularly when we think about this complexity of challenges and the idea of changing reality, as Bridget described it before. Now their households are, the holes in the walls are closed, and they have these baskets and so on. They changed very important routines, like going into the bush or not. Olayinka, I would like to hear your voice to these kind of different types of knowledges. And what kind of experiences did you have in the project? Bringing together these four voices you talked about before, is this also different types of knowledges? And what's your experience on that?
Thank you, Ute, and really lovely conversations going on. It's definitely important that everyone is on the table to talk. So in my experience, as rightly mentioned by most of the speakers, that thing of active listening, and as I hear speakers talk, and I'm like, okay, I think one of our key challenges remains the fact that you need to get an ethical approval, you need to have an idea of what you intend to do and get to the field, and then it's totally different. But in trying to come up with the whole design for the research, how do we bring everybody on board from the onset? It's also a bit challenging. So one of the things we have learned through this process, because we've used that approach for maternal newborn issues, nutrition-related issues, also Lassa fever. It's really about, and that's what Prof said, just having that beginner's mindset. And it's quite challenging. Going to the field without, again, you know something is wrong, and then you are asked to forget what you know and be really open. But it takes a lot of skills, but that's one of the key things that we've tried to do in how we do intervention or learn more about issues in a way that allows for collaboration and ownership. So one is around having that beginner's mindset that, okay, I'm here to really understand the issue. The other thing is, that's also been spoken about, is the issue of trust, community entry. We can't boycott those processes, and really getting the right voices to speak. When the keynote speaker was speaking, I was like, Northern Nigeria, and I'm like, the women that probably were on that seat were people that came, the expert or people that came to greet the emir or the chief. And so you would miss women's voices in such instances. And question goes in, how do you make sure everybody is equally represented? So she also mentioned the issue of around intentionality. There needs to be an intention to how we engage, how we make sure that the right people are talking. So in our experience as a project, we've gotten to the field, and data is telling you this particular community or has the highest burden on Lassa fever. And when you're having a town hall meeting, just to, again, following the community engagement process as Kadido talked about, again, outreach, involve, and in the involved stage, and they clearly told us that's not their problem. And so the first thing is, are these people in denial? Is the data wrong? What exactly is happening here? They said that wasn't their problem. Lassa fever was not an issue for them. Rather, it was newborn deaths that was more an issue for them than Lassa fever. And then you've kind of like chosen this as your study site, but that's not their problem. And so you can't ignore what their issues are. And so it's, how do you strike a balance? And one of the key things we did was, okay, take a step back and really go back to check, is the data we saw right or wrong? Okay, perhaps their risk perception is low, poor, and went back with an approach that kind of did like, what's it called? Journey map. Draw a story of the 5 prioritized issues they said they had in the community and walk them through using images to show, okay, newborn deaths, Lassa fever, respiratory infections. Again, let's walk through a story of somebody having this, and then again, this is the outcome. Another person having this, just to help them. Do they understand the issue? Do they understand? But again, bringing lives is more important to them than Lassa fever or deaths. So it's how do you balance such in such an instance? And it's really going back to key things many colleagues have mentioned around active listening, honoring people's story, coming with that, again, less ambiguity, that I know what the issues are, I know the solutions, but really, really the role active listening plays in participatory approach cannot be over and understated. The role observation, like Prof mentioned, again, ethnographic research, just really immersing yourself into their lives. And sometimes we always think that people need to make, again, giant changes. It could just be, oh, create a new pathway. It could just be like we see in some of the things they've said around COPE. Do you understand? Instituting a monthly sanitation or weekly sanitation. And I take, for example, also one of the work that we've done, and working with diverse stakeholders, the key thing people keep on shouting is people are not aware of the signs and symptoms. And so for the first 1 year of the project, we're hell-bent on letting people understand signs and symptoms of Lassa fever. And we did achieve, they did understand, and they were coming. Number of suspected cases increased in that community. But the problem was nothing changed. We still had high numbers. So it wasn't a case of signs and symptoms. Their behaviors, things they were doing in the community were part of the things they were doing their everyday life. At the end of the day, there was a whole lot of environmental issues that goes beyond signs and symptoms. And again, also as demonstrated by COPE, a whole lot, it's not about prompt care seeking, but if we're not able to understand the behaviors, the way this is how we store food, this is how we, again, just really understanding, observing, having an open mind will really go a lot way in how we engage communities. Over.
Thank you very much. I really impressed now. I think we could go on and on with this wonderful panel. I have to close the panel, but I would love to give as a closing statement to Dr. Fallah the opportunity to just give us a short, not summary, but you now in this discussion which is going on and showing so many different perspectives on this relationship, on this listening, on this being open, go with an open mindset. Please, I would like to invite you to close our discussion, and then we go into the last minutes for some questions of the audience. Dr. Fallah, please.
Thank you so much, Uti. So, I mean, everyone have touched a broad spectrum from Prof. Uka on the issue of where the knowledge is and listening and respecting the fact that local people have a knowledge, to Prof. Oliyenka speaking on the spectrum of the real issue. One issue I've seen is the issue of trust and managing expectation. Because if we destroy trust in the community participatory research, not only do we destroy our current intervention, but even future interventions. Their ability to open themselves up for a change is compromised. So building and maintaining trust, and one of the key things, as our speaker said, is to manage expectation. Do not promise what you cannot deliver. Sometimes it is difficult to have these hard discussions and say, I'm sorry, but we can't do this. And I probably will close with a very good example. So when we had the 2014 Ebola outbreak, there were secret burials. People were taking their loved ones and burying them secretly. And the only reason why they were doing secret burial was because we were doing cremation. Cremation was countercultural to us. When our system became overwhelmed, the Indian community in Liberia decided to offer us their crematorium. And our people panicked and rushed to do cremation without taking the cultural nuances. And as we listened to people, they told us that the reason they always buried was because they felt their ancestors were always around to protect them. But we've destroyed that by doing cremation, accepting a foreign culture to cremate. And so we got back to the communities after we listened to them and start to encourage them to allow us bury their loved ones. And so we got to this community, we promised them, and then they begin to call the number we gave them for the burial team. The burial team took 3-4 days to come. And I remember vividly this day I was driving and these two men came up to me and said to me, "Fala, you lied to us, you deceive us. You promised us to call the dead. You told us to stop doing secret burying. Now in our house, we have a dead body for 4 days. We've been calling the burial team and no one is coming." I was so hurt and the tears were just streaking down my eyes, and I called the Minister of Internal Affairs, who was then managing the burial team. I was so livid, and I said, "We're going to destroy every semblance of trust we have built. We are not responding to these people." I said, either you change the behavior of our response time or we'll walk away from this burial. And so what we did, we created a dedicated burial team. We created culturally specific appropriate teams. Like we had the Muslim burial team. Once we gave them the agency and the efficacy for them to call and for us to bury and not burn their bodies, we saw that cases begin to fall because no more were people bathing the bodies, they trusted over their dead bodies. So trust, transparency, managing what you promised them, ensuring that it happens is so critical because you destroy the current practice research and you destroy future research. Thank you very much.
Thank you very much. So listen actively, trust, and transparency in order to manage expectations. Thanks a lot. A wonderful pattern. Thank you very much. Unfortunately, Bridget got lost in this internet world. Sorry for that. I'm very happy that we had her statement in the middle. I say thank you to the panelists. It's a great pleasure. It was a great pleasure for me, honor. Thanks a lot. And I hand over, I think, to Oyin. Thank you again and goodbye.
Thank you very much, Dr. Hute. Thank you very much to our wonderful panelists. We've come to the end of the webinar, and while I invite Iris, I would implore all our panelists to quickly turn on their video just for a quick screenshot. And yes, just for a quick screenshot. Prof. Kadidiatu and also Dr. Mfala.
To say cheese.
Yeah. Just a quick cheese. Dr. Mfala, if you could.
Thank you so much for the opportunity.
Yes, please turn on your video.
Can we see your face again?
Okay, yes, I can see everyone now. Let me just quickly do that. Thank you very much. Iris, over to you.
Yes, thank you very much. And I know we are at the end of the seminar. I'm Iris Hunger. I'm the German part of the project of the project team and leading this project together with Dr. Chinwe Ochu. And I just want to say that it was such a joy to be together with so many people who support community-centered collaborative work. And it just feels like it's the start of a conversation. We are all learning together. That's That's what we heard so often during this afternoon. We do have a small and growing community of scientists at the Robert Koch Institute, where Eva and I are based, the German National Public Health Institute. So we have the small community of scientists who believe and practice participation, both in research and in action, and both nationally, because it's not a standard yet nationally to work participatory with communities. But it's a growing interest, but also internationally, and it's of course in this community where the home for the COPE, for the German part of the COPE project is. And before I close, I also wanted to mention that after COVID, I'm happy to see that centering pandemic preparedness and response in communities is now recognized even at the international level. You probably all know that the WHO has community protection, and that includes everything around communities in their pandemic preparedness and response concept. But for me, community is more than just kind of like the people on the ground. A community can also be the community of healthcare workers in a hospital, or a community can be someone like us who is trying to drive participatory methods forward. So with that, I would like to thank the keynote speaker. I would like to thank the panelists, our moderators, and of course all participants for being with us this afternoon, for sharing their views, for being engaged with questions. But most importantly, I would like to thank the team around Oyin and Eva who prepared this event, which of course takes a lot of preparation, and also for the nice slides that we saw for each speaker, etc. So thank you both very, very much. I know there were other people in the background, but I think it was the two of you who drove it forward. And yeah, just closing this amazing seminar and wishing us that we may be successful in moving participatory community-oriented health work forward for communities, but most importantly with communities. Thank you very much. Bye-bye.
Thank you very much, everyone. Bye. Thank you so much, everyone.
Thank you
Bye,
so much for the
everyone.
opportunity.
Thank
Thank
you for
you.
your time. Bye.
Bye-bye.
Again, thank you very much. Oh, Bridget, are you back?
Yes.
Yes, I'm back.
Thank
Hi,
you. Thank you.
Bridget.
Thank
Hi.
you. Thank you.
Thank you. I'm happy that we could hear you so well for your statement.
Thank
It was
you.
wonderful.
Thank you. Thank you.
Thank you.